Hello, everyone. My name is Jamie Moffa, and I'm here on the beautiful grounds of the Chateau Montebello in Montebello, Quebec. And today I'm going to be interviewing Jessica Merlin. So, Jessica, thank you so much for joining me today.
Oh, yeah, it's my pleasure. Thanks for having me.
Yeah, and can you just tell the audience a little bit more about yourself?
Oh, sure. So I am at the University of Pittsburgh, and I'm a physician and a PhD-trained behavioral scientist. And I run a center called Challenges in Managing and Preventing Pain, or CHAMP, Clinical Research Center at Pitt. And we do any type of pain research as a group. Me personally, I focus a lot on the intersection of pain and opioid misuse, opioid use disorder across different populations and settings. So populations being people with HIV, people with advanced cancer, settings being primary care settings, and opioid treatment programs.
Yeah, and you gave a talk yesterday, which was really fascinating, and it actually inspired me to think about systemic challenges in implementation.
Oh, how wonderful.
Yeah, for
That's
pain treatments.
Great. Yeah, so I've been moving much more into not just intervention development and testing, but implementation, really trying to understand what the best strategies are for implementation of a particular intervention in a particular setting for a particular group of people, and then testing implementation strategies is the next step. So yeah, I'm very interested in that too. I think that's great. I'm glad that had that impact. Yeah.
Yeah, I think it's really interesting because, you were just alluding to implementation is not the same across different settings and that you need to tailor how you're implementing different treatments. But at the same time, I was thinking about a lot of different systemic barriers to implementation, things like insurance costs and long wait times for clinics. So I don't know if you just wanted to talk about the duality of needing to tailor implementation, but also needing to deal with these big top-down factors.
That's a great question. Yeah, I mean, I think the challenge with implementation is thinking about it in a multi-level way. So there are things that you might need or want to do at the clinician level, at the patient level to facilitate implementation, but then also at the clinic level or at a policy level. And so policy levers can be much harder to pull. But for example, you mentioned insurance. So in the talk yesterday, I was discussing this HIV intervention for chronic pain in people with HIV. And I think if you can show that an intervention like that is cost effective and has efficacy and effectiveness for clinical outcomes, then it's a powerful argument to payers. And I mentioned yesterday the federal Ryan White program. It's a program that funds a lot of HIV care. So I think a powerful argument to payers. That's also something that we have to think about as we're designing things and testing things.
Yeah, for sure. And have you engaged in any advocacy at state or national level?
I have, but not in this domain. I want to do more. I aspire to do more advocacy work and have started thinking and planning a little bit of how I might take some time to do that, particularly related to treatment of opioid use disorder and in people with pain often who have serious illness for whom it's extremely difficult to access treatment. But treatment access is a big issue in opioid use disorder just across the board. And certainly there are racial disparities. And so there's a lot there. So I've been thinking about that a lot. But I've done some advocacy in the immigration space, actually. It's just a really personal passion and something I think that's just really important. But it's not my academic focus.
I think that's important, too. I oftentimes think academics can get into this mindset of you have to be 100% focused on your work. I've also done a lot of advocacy and organizing outside of my work. So it's good to hear someone who's a little bit further on in her career than me say, yeah, this is something that I do.
Oh, no. Right. Oh, I'm so glad you said that. People always ask the question, how do you decide what to do, what to take on or say yes to? And I think some of it has to do with building your niche and making connections in your field and working with people that you care about. And those are all really important. But then you also have to take on things that really feed you and speak to your values and your interests and passions just globally. So I think that's really critical. And I think as a physician and as a researcher, we have a loud, privileged voice in society that, for better or worse, especially as a physician, I think using that position to advocate is important.
Yeah, I think this goes to as well, something from your talk that struck me was you talking about how your career trajectory doesn't have to be linear. even when you're in your career, what you do doesn't have to be linear. So can you talk a little bit more maybe about that nonlinear trajectory?
Yeah, absolutely. Well, I guess I should explain a little bit about what my nonlinear trajectory is. I think the biggest thing that may be nonlinear about me is that I spent most of my life thinking I was going to be a doctor that takes care of patients full time, maybe does a little medical education. But at the very end of my medical training, I realized that I actually liked research. I had one research project, had a wonderful mentor, got a little glimpse of it, and was given a really amazing opportunity to dedicate a lot of time to research in my first faculty position, even though I didn't have any grants or training. And somebody took a risk on me, which I'll be eternally grateful for. And then even after that, I started off, my training is in infectious diseases and palliative care. I started off working on pain and HIV, but pain and HIV naturally grew to an interest in opioids, which are commonly prescribed, and then opioid misuse and use disorder. And that grew into a really strong interest in addiction. Now I'm boarded in addiction. My clinical practice is actually addiction treatment in patients who have advanced cancer, pain and addiction in patients who have advanced cancer. It's like a palliative care clinic that treats pain and addiction and advanced cancer. So it's twisty and turny, and I feel like I've reinvented myself a little bit a couple times, where I have a couple parallel lives here, but probably both. But I think there's this quote, and I always forget who it's attributed to, but chance favors the connected mind. But I think that's really true, that if you put yourself out there and are open to things, that you'll be able to jump on and be nimble about things that come up that could potentially be something really interesting and neat and complement what you're already doing. And so when I was a fellow, I was at Mount Sinai, New York, and I had lived in Philly the previous 10 years. And this position came up in Alabama, which at the time was really the leading edge of the HIV epidemic in the US. And that's what I was working on. And I had never lived in the South. I'd never been to Alabama. I don't think I'd been to any neighboring state other than Florida, never to North Florida. But I was lucky that I was at a point in my life where I could do this. I had a partner who, my husband, who is very mobile. He works for himself. And so I was privileged to be mobile. And a lot of my colleagues and my friends were like, you're going to move halfway across the country where you know nobody. But I was like, yeah, this is where the work is. This is where the need is. It's an R1, excellent academic institution, really strong public institution. So I am. And I was there for 6 years.
Yeah, it sounds like a key component of all this has been openness and flexibility. You never were too rigid about I need to be doing this right now.
Thank you. Actually, I appreciate you saying that. As a physician, you're kind of on this treadmill, right? It's like med school, residency, fellowship. And I think I was just do what everybody else is doing, just take the next step. But once I got creative and combined infectious diseases and palliative care,
I feel like that's not a common combination that you hear about.
No,
right?
There are very few of us. Yeah, not a very common combination, but then, which meant that I had to think about my career a little bit differently because I wanted to improve pain management in people with HIV, which really is a research question and not so much a clinical one. It's a clinical one once you have some research answers.
Because then it's, well, how do we apply this research so we can actually improve pain in patients with HIV?
Exactly. And when I started, we were so far from that because there was so little literature in that space. And it was like, well, clearly, if I'm going to work in this space, research is the way to do it.
Yeah, that area of research was also something that caught my eye because of how HIV has transitioned in a lot of ways from a very devastating acute disease to, for the entirety of my lifetime, it's been something you manage very chronically, and how to follow those patients and work with them on multiple aspects of their health. Do you work with other providers, other disciplines with these patients?
So in 2024, HIV is a chronic disease for people who know that they have HIV. So they're diagnosed, they're connected to treatment, they take their medication and are retained in treatment. And that is saying a lot. So to get all the way to the end of that, that's actually an important public health target, is raising the percentage of people who fall into that category, right? But once people are in that category, are maintaining that, then they can do very well, but they have a lot of other comorbidities. rates of, for example, cardiovascular disease and malignancies, and then chronic pain, mental health comorbidities are all higher in this patient population. And the way that HIV care is set up in the US is it's often funded by this federal Ryan White grant, which has a mandate to provide essentially multidisciplinary care, interdisciplinary care to people with HIV. So these Ryan White care settings, they vary. They're not a monolith by any means, but they generally have not just the biomedical physicians, nurses, but also social workers, therapists. Sometimes, like in the setting that I worked at UAB, it was a very robust multidisciplinary clinic. We had a psychiatrist, we had psychiatric nurse practitioners, and we had other medical specialties in there. So we had kidney doctors because, you know, people with HIV are more prone to kidney damage from medicines they take.
I was going to say they're on a significant regimen of medications.
Right, exactly. So, you know, there's a nephrologist in there and a dermatologist in there. So folks who had specific expertise in these specialties as they related to HIV. And I was there as the palliative care and pain person. And 99% of what I did was biobehavioral management.
And is that chronic pain from the virus, from the treatment, from other reasons entirely? Do we know?
That's a really important, not fully answered question in the field. So we know some about the biology of pain in people with HIV. Some of the work that we've done, we've looked at people who have either chronic widespread pain or no pain. There's a difference in IL-1 beta. So IL-1 beta is higher in people who have chronic widespread pain. So that's one thing we know. And then another thing that we know is that in smaller studies of quantitative sensory testing, so inflicting pain on people in IRB-approved ways in the lab, when we do that, and this is some work that I did with Burl Gooden, my good friend and colleague, found that people who have HIV who have virus in their blood have a higher pain sensitivity than people with HIV who don't have virus in their blood, and they have higher pain sensitivity than people who do not have HIV. And we also know that even in people who are virologically suppressed, who don't have virus in their blood, which is the biologic endpoint that everybody's aiming for in a patient, even in those folks, they still have inflammation, elevated levels of inflammatory markers, and that's why they have higher risk of cardiovascular disease, for example. And so there's this question about, could that be the case for pain? The other thing is that people with HIV are at the intersection of mental health and addiction. Not everybody, but just as a population. And so is pain. It's just a super saturated population of individuals who are just more likely to have pain because of their comorbidities that they may come into their HIV with or develop after their, HIV diagnosis. My guess is it's probably some of both.
Yeah, a little bit of all of the above.
Exactly.
Which is kind of how a lot of medicine is, as much as we try to push it into this was caused by this and this was caused by this.
Yes, people are complicated. One of the things that I always enjoy about being here at NAPS, well, this is my first time at NAPS, but one of the things I really enjoy about NAPS and I enjoy about being around basic scientists is it's really fun to hear about how you can manipulate things in an animal in a way that you get a kind of predictable response. I don't know if my animal colleagues would agree with that, but generally, hopefully, you get kind of a predictable response. And then humans are messy.
Right. Yeah. I work with mice. I have definitely been wrong about a lot of my predictions. But at the same time, they're all genetically identical and they all live in identical cages. And we're manipulating at a most 2 or 3 different factors.
Right.
Clinicians who work with patient data and researchers who work with large aggregated data about human subjects have to do, in some ways, a lot more work to make the data make sense.
Yeah, it's true. I'm thinking about a study that we're doing where we're trying to understand the benefits, harms, and decision-making around opioid therapy for people who have advanced cancer, because as weird as this sounds, even though opioids are first-line treatment for advanced cancer, the randomized trials that we have are almost exclusively opioids versus opioids, not opioids versus placebo. So we don't have a lot of literature on this.
Right.
So, and I would go as far as to say that in 2024, it would probably be unethical to do a randomized trial of opioids versus, or you would just not get any participants of opioids versus not opioids in people with advanced cancer. That's a hard sell for understandable reasons. If it would even pass muster ethically. And So we're doing an observational study
Right.
where we are recruiting people who have advanced cancer within 12 weeks of their diagnosis and following them forward for 2 years or until death to collect data on them about, A, do they develop pain? Because not everybody does. Probably more than half will, but not everybody. And then once we see about their pain development, then are they prescribed opioids and what their experience is with opioids?
Yeah. I think that the other thing from your talk that really caught me, and I wrote it down in my notebook and bolded it, is running towards the fire.
That's so funny.
You might have said run screaming towards the
Yes,
fire.
I think I said screaming. Yes.
That's pretty great.
Thanks. I appreciate that. Yeah. And I think in science and medicine, there are a lot of really complex problems. And I think the more we embrace that and try to look for the complex problems to solve. I saw someone post on Twitter something I said after that, which was something I said yesterday about complex problems and complex patients call for the most attention.
Yeah.
And so I think a lot of the healthcare system is not set up for people with a lot of complexity. And most people don't fall into neat little buckets, or many people do not fall into neat little buckets.
Right, which anyone understands intuitively. But then when you start to try to work within the healthcare system, all of a sudden it's like, well, no, you have to use this diagnostic code, or we're following this treatment regimen, and it's pretty inflexible. Insurance especially is pretty inflexible in what they'll let you do,
Yeah.
what they won't let you do.
Yeah, for sure. So some of the clinical work I do is this outpatient clinic that I mentioned before. It's a palliative care clinic that's embedded in an addiction treatment program. So we treat patients with advanced cancer who have pain and also opioid use disorder, other substance use disorders. There's very little literature on how to best manage patients in this situation. And we've worked really hard to try to contribute to that literature with some of the work that we've done. But within the healthcare system, there's really nowhere for these folks to be managed. So palliative care clinicians often feel unprepared to manage substance use disorder, and then addiction physicians may be unprepared to take care of somebody with a very serious illness, especially since many addiction treatment settings are fairly rigid.
Right, and what they're able to do.
Well, or what they're willing to do. They don't have to be that way, actually. But for example, methadone regulations have relaxed some in the post-COVID era. And, many methadone clinics just choose not to relax. Relax is probably not the right word because it implies that it's lax in some way, but it's not. There's no evidence base to this type of structure. And so even when allowed to be more flexible, they're not. So we put up these really unnecessary barriers for people. People aren't able to get the care they need in the palliative care space, in the addiction treatment space, definitely not in the oncology space.
Right.
And then it's sort of like all, as everything else does, falls on the primary care clinician who really
are
feels
overworked
like
and like really quite unable to handle such complexity just due to, again, systemic pressures, time, resources, sometimes training,
expertise. They may feel also really unprepared for this. So these are folks who really have nowhere to go in the healthcare system. And so I have this tiny little clinic making not really a very big dent in the systemic problem, but I'm trying to make that dent with research to try to understand how do we implement strategies that we now know are the best strategies to take care of these patients. How do we implement that?
Because you can have like
system?
The best solution. And if you don't actually talk about how to implement it, if you don't actually go around talking to all the people who are involved, patients, caregivers, providers, and figure out what they need from their treatment, then it's not going to go super far.
Yeah, exactly. We did a Delphi study. So basically convened a panel of experts in palliative care and addiction to try to understand what the most appropriate management is for various types of scenarios of people with pain and opioid misuse or opioid use disorder who have advanced cancer. And a lot of good things came from that. We know that it's important to continue addiction treatment, sometimes to start it if it hasn't been started pharmacologically with buprenorphine, et cetera, et cetera. But just taking that small piece as an example, prescribing buprenorphine to treat somebody with an opioid use disorder. Until recently, it was only allowed if you had a special license. Now there's no more X waiver, so anybody can prescribe buprenorphine to treat opioid use disorder. But I'll say this, despite the fact that it's available and people can do it,
many
people still
don't.
aren't doing it.
Yeah.
And so figuring out why that is and how to make it happen and where should it happen. Should it be the oncologist? Probably not. But should it be the oncologist? Should it be the primary care doctor? Should there be a special way for a healthcare system to address and care for patients in this situation that's multidisciplinary? I don't really know what the right answer is, but we're doing interviews now of exactly as you said, patients and clinicians to really understand that better, to try to develop implementation strategies that we can then test in this space. That implementation piece is so critical.
And it's something that I think maybe not a lot of people give that much thought to, either because you're just doing what has been evidence-based practice for many years, or you think, yeah, logically, if this is the best thing, then everyone will just take it up.
Right. It turns out that just telling people to do stuff doesn't work, whether that's a patient or a care partner or a clinician. Christine Chambers said yesterday in her brief talk, the timeline from evidence to implementation is 17 years. And so little of what is evidence-based actually makes it to treatment and to implementation. And so closing that evidence practice gap, like the whole field of implementation science. But it's a newer field. And there are not enough people trained in how to do it and how to do it well. I'm working on getting some training in that space. I'm participating in a certificate program at UCSF. I'm about 3/4 of the way done with, which is great. And there are other ways to get training in it. I've done like 2-day workshops and things like that. And then I'm trying to mentor a bunch of folks in that space, and we're all learning together.
That's really awesome. How has that certificate program been?
Amazing. I love it. It's fully online, as you would imagine, and there are people from all over the country doing it. And it is the most well-run online thing I've ever participated in, because it's so, I was just emailing the instructor for this last course I just finished a couple weeks ago, and they know how to make it really, really interactive, and the quality of the instruction is really high, and people giving feedback on your weekly assignments are really, really skilled.
That's really good. I feel like most online things, people just leave incredibly frustrated.
No, I think this is a really good one, a really high quality one. I do enjoy going to things in person. Brown offers that 2-day course. But they have an implementation science center there that offers it. And that was really spectacular. And it was in person. And so I went with a bunch of my mentees, and we occupied a big table up front.
Nice.
It was so awesome. It was so great to just all be learning together.
In medicine, sometimes you are just going to have to make tough choices, but sometimes the tough choices are because the system's been failing for a while.
Correct.
And it's just that this stress pointed out the way in which the system had already been failing for a while.
150%, yeah. Just fundamentally not having universal health care in the U.S. makes everything not work. And so for my patients, I have clinic every Friday morning at least, but not the ideal time to have a clinic like this, because I spend the morning seeing patients and the afternoon dealing with pharmacies, trying to figure out how we're going to get the patients the medications they need before the weekend. And when everybody is gone, and hopefully including me, because for a variety of reasons, pharmacies, they can't order meds for people. It could be because insurance and prior authorizations, which take 24 to 48 hours. So that's going to be a Saturday or Sunday. So now I'm trying to write 3-day or 2-day supply of a medication for somebody until the PA comes through that they have to pay cash for, because there's no other way to make it happen for them, or because they have an opioid use disorder and they have advanced cancer and pain, and they're being prescribed both buprenorphine and a full agonist opioid, and there's confusion or lack of knowledge, really. Some physicians are knowledgeable about this, some are not. Some pharmacists are knowledgeable about this, some pharmacists are not. But sometimes the pharmacist is really not necessarily knowledgeable about this. And doesn't think you can prescribe buprenorphine and a full agonist at the same time. And I have to explain, no, actually you can. I mean, I get this from physicians too, but physicians are not the barrier in this specific case. And sometimes it's the insurance company that I'm having to explain this to. So it's all before 5 p.m. on the Friday when everybody is inaccessible.
How do you manage practicing medicine in a situation where you're like, I know this could be better?
It's very frustrating. I think part of how I manage it is being a researcher, at least, you know, trying to work to improve the care we deliver and recognizing, as you said before, that some of that implementation work is actually policy change, which is why on the horizon for me, and I'm trying to figure out how to best tap into this, but on the horizon for me is more policy and advocacy work to try to make these changes. I mean, the first thing I've maybe done in that space, I guess, is that one of my wonderful mentees, Katie Fitzgerald-Jones, who's a nurse scientist and works also in this space, she and I and a few other folks wrote a policy piece for the New England Journal that was published in November, talking about the kind of ridiculous situation that people with serious illness are in when they try to access methadone treatment. You can imagine a person who has been getting methadone treatment for 20 years and is pretty stable on it and doing well. And then they get a new cancer diagnosis, and now they have to spend a ton of their time accessing cancer treatment, and then also a ton of their time standing in line at the methadone clinic, which they may not be physically capable of doing, and following some of the inflexible policies, like now that you're being prescribed oxycodone for your pain, you now have quote unquote failed your drug test and have to come in every single day, even though you used to have take-home privileges. It's like managing 2 full-time jobs, and that's what we're asking people to do just to stay alive. Stay alive related to their cancer, stay alive related to their opioid use disorder, and have to pick which one they're going to prioritize.
Right, which is not a situation anyone wants to be in when they've been diagnosed with cancer.
Well, right. Would you ask somebody, you could either treat your diabetes or your hypertension? I mean, either way, it's going to be a huge pain and very difficult and obtrusive and interrupt your life miserably, but you can just pick one, diabetes or hypertension, which is it. What kind of perverse universe is that? But that's what this is. So we really make people choose, and neither choice is really a good one. So the answer to your question of how do I work within a system like that is to try to shed light on some of these issues through research, through writing, and hopefully through other vehicles for policy and advocacy.
And maybe this is a bleak question, but do you have hope for that avenue? Do you think that we as physicians and scientists can make change through advocacy?
Yeah, I think so. I mean, getting the X waiver to begin with and being able to prescribe buprenorphine in an outpatient setting was policy and advocacy. And that opened up a lot of avenues for, an important tool for people. And there have been some changes in how methadone can be accessed in terms of liberalizing the take-home process and things like that. The thing about methadone policy is that even though it's federal, it's also extremely state-specific. For example, in New York, where there's a lot more progressive thought around how to do things, and where some of the policies also allow for a little more flexibility. The state of New York runs methadone bans, like go-to people. Like these are the types of low barrier interventions that we need.
It's such a simple idea. Bring the thing to the people.
Isn't it though? Yeah. We have a bupe bus, a buprenorphine bus in Pittsburgh, but with a similar concept. But because of our state regulations regarding methadone, we can't hopefully yet have vans for methadone or buses. But in states where people have been able to take the current regulatory climate, address it to the best they can, and then work within it in a way that gets care to people better. I mean, I think it's possible. In some places, and to varying degrees, it's possible. And I think it's possible in Pennsylvania, too. I think it's just maybe going to look a little different and take a little longer.
I guess before we wrap up, is there anything else that you wanted to say? Or something you wish that I had asked?
No, I don't think so.
Thank you.
It was my pleasure. Thank you so much.